Welcome to the STARS program, seniors taking active roles in society. And now, here's your host, Anita Finley.
We're going to have an ophthalmologist named Monique Barbour. Dr. Barbour is located out in Lake Worth, and we've had her speak to us before. As a matter of fact, she's going to be one of our distinguished speakers at the upcoming Cure Symposium, April the 9th. And I thought a good topic for us all today would be talk about lasers. It seems that everywhere we read things about lasers, and I don't think if someone wanted to describe it, they could really describe what lasers are when they're talked about with vision. I know that we do have lasers now for faces, for all sorts of things. So what are we talking about with lasers for eyes, Dr. Barbour?
Well, actually, good afternoon, everyone. We have a variety of laser treatments for the eye, and honestly, it depends on the condition in which we're treating. So we can use a laser to treat glaucoma. We can use a laser to treat diabetic retinopathy. We can also use the laser to correct your vision. And the latest thing, Anita, with so much excitement, is laser-assisted cataract surgery.
Really?
So that is, yes, absolutely, where the laser actually performs a portion of the cataract surgery.
Well, that is new and exciting, especially for our population. Well, tell me how that works.
For laser-assisted cataract surgery?
Yep.
It's actually performed when we make an assessment for the patient to make sure that they're a really good candidate for the procedure. There are some calculations that are done on the eye. After that, we calibrate the laser, and a small ring goes onto the surface of the eye. This ring then holds the eye in place. After that, the laser then is responsible for making the incisions that we use to get to the cataract. For example, the incision for cataract surgery is now right about 2.5 millimeters, very tiny. So the laser will then perform in a way that makes the incision for the entry into the eye. After that, the laser actually prepares the cataract for removal. The laser will actually cut a window into the capsule of the cataract, allowing access to the cataract.
And does the person who's having the
cataract will actually is able to be fragmented following the opening of the capsule. The cataract is fragmented into small pieces. So this allows the cataract to be softened, and subsequently the doctor would then have to perform the rest of the surgery by acerating the cataract and placing the implant.
So, yeah, the implant, of course, that's the most important thing. And since you're on this and talking about it, there are different kinds of implants, aren't they?
Absolutely. We now have the implants to correct every error, every refractive error of the eye. The implants can correct nearsightedness, farsightedness, astigmatism, as well as presbyopia. The latest implant that has hit the market is one that's manufactured by a very well-known company called Bausch & Lomb. They have now made commercially available to all surgeons in the United States a lens called TrueLine. This lens is truly revolutionary in that it can correct astigmatism as well as presbyopia, which is the need to use glasses for reading up close. So we have it all now in one device, like a bionic piece of material that goes into your eye that can correct your vision to the maximum.
And is it painful?
The cataract surgery is not painful, and the laser is not painful. So the laser portion of the surgery is done before the implantation of the implant. The patient is brought into the room and is given a sedative before arriving into the operative suite. So a sedative is given to help the patient relax, and we also give eye drops to make the eye, to anesthetize the eye prior to any procedures. So the patient does not feel any discomfort.
And then can they see right away?
Most people are able to see within a couple of hours of the surgery. Most of the time, the next day is when we get the wow factor. In particular, if the patient has not been seen very well in the days and weeks prior to the surgery.
Yeah, when you just step back, I mean, you're young, but you're not that young that you knew that this was not something that happened casually. I mean, when you first went to medical school, I bet a lot of this wasn't there.
And nothing like this beyond my wildest expectations.
Right. And so as a physician, I'll bet this is exciting to know that the people who you deal with are now going to see.
Absolutely. It's a very rewarding career.
Yeah, I know it is. It is, especially now with the amount of older adults who are having this. What age typically are you dealing with cataracts? Do you see people that have that?
I would say that the average age is probably 65.
Really?
But we do have younger patients, and these are patients who are at risk for developing cataracts. They have other illnesses, comorbidities such as diabetes, which put them at risk for developing cataracts earlier than someone else.
And can just describe to people so that they know that they ought to do something. Probably, since it doesn't happen all at one time, that things just get more foggy and they just can't see clearly, and maybe they don't really understand that they have cataracts if they haven't been to a doctor.
That's a very good assessment, Anita. It's not uncommon that I see patients who clinically appear to have visually significant cataracts, yet they have no complaints about their vision. On the other end of the spectrum, I see patients with the lightest amount of opacification, and they're already complaining about nighttime glare or not being able to see very well, even with the best glasses. So
it
it's
affects,
very subjective.
Yeah, it affects nighttime glare. Is that how? It's not just as foggy, but nighttime is the big problem, isn't it? That they don't really see well.
Yes, nighttime glare is a very limiting factor, and it's very motivating portion of the reason why a patient decides to have cataract surgery.
Okay, so now that we're still on the subject, talk about the particular kind of an implant that they have something that's Superman, and then there's some that, you have to choose. You want a right or a left to be distance or near, or people have to make all sorts of decisions.
Yes, there's some wonderful options right now with the technology, in addition to the True Line implant, which I spoke about a few minutes ago, that corrects not only astigmatism, but also presbyopia. We have lenses that will just correct astigmatism. We have lenses that can correct presbyopia so that you don't need to wear reading glasses. With the initiation of the laser now, with the laser-assisted cataract surgery, the laser does correct astigmatism as well. So it's quite common that we have a scenario where a cataract patient has a significant amount of astigmatism, and they also want to see very well, and they also choose to have laser-assisted cataract surgery. So this puts the patient at an advantage to experience the most highly technical cataract procedure that's available right now, to have laser-assisted cataract surgery correct the astigmatism while placing an implant that corrects the presbyopia so that they are able to see just about everything with independence from glasses.
And do you find that these operations are like 95% perfect?
Well, in ophthalmology, we shy away from using the word perfect or perfection. In all honesty, there's no guarantee. And I am at the mercy of my equipment that makes the pre-surgical analysis in terms of choosing the implant power. So this is something that is very challenging, and I usually repeat my pre-surgical measurements and try to choose the implant that I think will be perfect, so to speak, for the patient. But we sometimes have surprises, and occasionally we have to enhance the outcome at the 3-month period where the patient is not seeing 20/20. We are able to go back with a laser or another kind of surgery in the office to help them see better.
Really? That's excellent.
Yes.
I didn't know that. So you can you use whatever, as you said, you do what the formula says, and then if there's any kind of a quirk, you can go back and relook at it.
Absolutely. So this is as it comes to cataract surgery. With regards to laser vision correction, and this is when we correct the vision using the laser, not cataract surgery, this surgery is done on the surface of the eye, on the cornea. And so the patient will have, the measurements, and we call it a refraction prior to surgery. And so we rely on the refraction and the present state of the patient's refractive error to tell us what to punch into the laser for laser vision correction. Just doing a surface ablation is a wonderful procedure. It allows patients to have really, really fine, crystal clear vision, and within a short amount of time as well. And the recovery is usually almost immediate, but for most people it may take 1 or 2 weeks for them to see what their best correction is.
So we're really looking at people who have given up driving, and now they can come back and drive again.
Absolutely. Absolutely. We've had patients who require assistance with their activities of daily living, with things as simple as looking at their food or seeing a photograph of a family member, and they had simply given up. And that's the rewarding part of what I do. I am able to restore that basic everyday function so that people can have a higher quality of life.
Yep. That's a good thing. And actually you have an optometrist there, and so if people are just looking to have new glasses or to have just tests, they can do that if they don't have anything more serious.
Absolutely. Yes.
So what people should know, especially after the age of, should be younger, but let's say at the age of 50, they should really go once a year and have a test by an ophthalmologist who will review their eyes. And then if you feel they should go to an optometrist, of course, for glasses or optician, then they have everything right there.
Yes, we do. And we're very proud of our operation. In Lake Worth, we're located near the Turnpike on Lake Worth Road, 7657. We have a full scale of optical as well as optometry services and ophthalmology, so that we can provide just about every service that you need when it comes to your eyes.
And I'm going to give a phone number for people. You have to make an appointment. That's how you do this. You would call 561-432-4141. Again, 561-432-4141. It's very easy to find, as Dr. Barbour said. It's just right there on Lake Worth Road at 7657. But also go on their website, which is Clearview Now, which is Clearview is VUE now.com. Clearview Now. And for those of you who haven't decided to come to the Cure Symposium on the 9th, make sure you do that. Then you get to meet Dr. Barbour, and if you have any extra questions, you'll be able to hear them. Dr. Barbour, I know it's off the subject a little bit, but tell us how everything's going in on your not-for-profits over there in not Belglade, but actually what is it again?
In Pahokee.
In Pahokee,
actually,
right?
Yes. Right now, we are doing some of the background work to prepare for our upcoming event, which should be in October this year. We will be sponsoring again a 5K run with the hope and promise to educate people in the Glades area and specifically in Pahokee about diabetes and the impact that it has on the eyes. It is very moving to me that we're seeing an increasing number of cases of diabetes, and following that, we are seeing an increasing number of patients with diabetic retinopathy because they are diagnosed so late in the process that their eyes have already been affected, and these patients are getting younger and younger. So I was prompted to reach out to the community in which I serve to make them aware of this, and I'm going to hopefully be able to achieve that through the 5K event that we will be hosting later in October. So we're gathering now a list of sponsors, and we're putting information in the hands of patients that are presently coming to the office out there.
Well, let me tell you, we have one of our sales executives and I have a meeting with someone who has a home health agency in Belglade. We have a meeting on Monday, and we are going to tell them about you and what you're doing with that, and maybe you can hook up with them.
That's fantastic. Hopefully we can work together.
Yeah, I'm just thinking about that, definitely, because, you know, the county is so wide from east to west, and she's a darling woman. I don't remember the name of the home health agency, but I'll get it for you, and we'll have her contact you. Yeah, this could be a whole new thing then. You know, that's what we like to do. We like to network with everybody.
Absolutely. Thank you so much for asking.
Well, it's
Anita.
important because you are very good to do this. And something you were talking about with the diabetes, that's really key. And you are right. So many young people now have that. And so I don't know actually if you have diabetes, does that cause cataracts?
It can. It can also cause glaucoma. So we're seeing not only the retinopathy, but it seems to be a triad of retinopathy, glaucoma, and cataract in the same patient. So it's very challenging to have to address all three of those issues in one patient at the same time. But I'm very aggressive when it comes to making the analysis and going forward with the treatment as well.
We haven't talked much about glaucoma. Why don't you tell people what that really is and what happens?
Glaucoma is actually, in ophthalmology world, we call it the silent thief of sight. It is a disease which degenerates the optic nerve of the eye, and that is the bundle of life and images that are projected to your brain so that you can perceive your world outside. The optic nerve is slowly but surely degenerated and obliterated with this disease. Some people are at high risk for this disease because the pressure in the eye turns out to be elevated. But we also see glaucoma even when the pressure is not elevated. When we do see elevated pressure, we treat the pressure with eye drops. We lower the pressure by about 30%, which is what all of the studies from the National Institutes of Health promote. And this is the standard of care in ophthalmology, to lower the eye pressure as much as possible. So we make a series of tests to confirm the diagnosis. I take photographs of the optic nerve to demonstrate to the patient as well that, yes, the optic nerve looks abnormal. And then we go forward with an analysis which includes a visual field test and a very detailed analysis of the optic nerve where we measure the thickness of the rim and the neural tissue of the nerve and compare it to others of the same age to make the diagnosis, to nail that down. After that, we set a target for which we think the eye pressure should be. And then I will institute one of the eye drops to achieve that goal. And we follow the patients along to make sure they're not progressing. Once the damage is done, glaucoma is irreversible, Anita. It's irreversible, and it can be damaging to the point where a patient loses some of their fixation, and ultimately they lose their sight.
And it sounds like they don't have to. It's one of those things. It's not like some diseases that you can't do anything about. It sounds like there's a lot of prevention, and if you go and take care of that, and you get those drops, and
exactly.
and you take care of the drops. What's in the drops that make the pressure go down?
Well, the drops are formulated to target the receptors and cells inside of the eye that are responsible for producing the fluid that bathes the eye. So we have, several different classes of medications to treat glaucoma, and they all target the cells in the eye to either reduce the production of the fluid that's produced or enhance the outflow. Now, on one end we have all of the drops. We have about 4 or 5 classes of medication to treat glaucoma. On the other end of the spectrum, we have surgery to treat glaucoma. We have filtration surgery when we're releasing the pressure from the eye. We can use devices to do that, tube shunts, or there's a way to canalize a portion of the eye, make it more efficient so that the pressure can be lower. In between using drops and glaucoma surgery, filtration surgery, we do have lasers for treating glaucoma. The lasers target the drainage canal in the eye, and they basically make the drainage canal more efficient and allow the pressure to be reduced.
Well, this is interesting. I know you're not a vet, but talking about eyes, my dog's eyes, I give it drops because it has the tear ducts apparently are not functioning, and I give them twice a day. I put drops in her eyes.
That's very interesting. Which kind of drops are you?
Well, I don't have the name. It's prescribed. No, I mean, it's a prescription. And then I do go to I do have to add also those little tear drops that you buy over the counter. I forget what it's called. They're just like a little drop, and it looks like it's thick. And you put it in there. I don't remember what they are. But I do that twice. Yeah, she gets it in her eyes twice a day. And I had taken her. Actually, they have a vet ophthalmologist. Yeah, the pet told me. The pet doctor, the vet said, "Well, I really want you to do that because I don't want her to go blind." And he did a big thing on it. And he said, if you keep, I think the name is TAUREN, something like that. That's what gets in my brain, but it's probably not true. And she's very patient. He also tells me this is funny, we're talking about it now, but he wants heat on the eyes first, so it opens up something. So when the drops go in, they're better. He took
that is very interesting.
It is. He took he took pictures of her X-rays of the eyes and all, and she's doing fine, I guess. I mean, you can't see, but that's it. Even if you have patients, I'm sure, with dry eyes. What do you do for them?
Well, interestingly enough, dry eye is a very broad spectrum illness, and it is multifactorial, so many causes of it. We usually start by trying to determine what's causing the dry eye. Is it from the tears being evaporated too quickly, or is it because you don't produce enough tears, or do you have a comorbidity such as acne rosacea, which is causing your tear film components to be unbalanced? So after we determine or try to determine the cause, we then usually start with some kind of tear replacement. I usually recommend artificial tears, over-the-counter, non-preserved, usually the pharmaceutical brand, not the store brand, because the store brand tears have quite a few preservatives in them. After having the patient use artificial tears for a couple of weeks, we usually do a follow-up to see if they've improved. And if they haven't, we go on and explore other options, such as adding in fish oil capsules, omega-3s, or trying Restasis, which is a prescription drug for dry eyes that helps the patient's eye produce more tears. There's also a device that we can put into the eyelids called tear plugs, and those are very effective. They keep the tears from evaporating too quickly. The latest thing in dry eye therapy, Anita, is something that we call LipiFlow, and this is a device that helps the glands in the eyelids produce a more balanced tear film. This treatment is in the office, and an apparatus is placed on the eyelids for about 15 minutes, and it actually warms up and it massages the eyelids so that the glands are physiologically more efficient. This treatment, called LipiFlow, again, it takes about 15 minutes to perform it, and it actually relieves the dry eye symptoms for most patients for up to a year, and allows the patient the freedom of not having to use drops every day for at least a year. And we've been really surprised and seen the progress and the outcome of our LipiFlow patients. They have been very pleased,
so
I'm glad to report it's a wonderful treatment.
So you call it LipiFlow?
Yes.
Well, we may have to talk about that at the Cure Symposium. That sounds wonderful. Well, we've just run out of time. You can go have your lunch, and this was super. I thank you so much, very much, and we'll be getting that other information for you that I talked to you.
Thank you, Anita. Yeah. I'm looking forward to seeing you.
Yes,
and
I am also.
On the 9th.
Thank you so much, Dr. Barbour.
Thank you. Have a good afternoon.
You too. Bye.